Terrific. So hello everybody, and thank you so much for joining us for another one of our Meet the Specialist sessions. Today we have the very interesting Dr. Steve Flecknoe-Brown, who is a general physician and a haematologist. Haematology is a bit of a mystery to most people, and so I hope he's going to be able to shed some light on it for us all. But it is my understanding that haematology is all about blood and the management of blood and the things that can go wrong with your blood. And because if our blood doesn't pump around our bodies, we die, it's pretty important kind of stuff. Anyway, thank you so much, Dr. Flecknoe-Brown, for making time for us today. And I'll hand over to you to tell us a little bit about your specialty and your expertise.
Thanks, Michelle, and thanks everybody for joining. As introduced, Steve is my name, Stephen on Sundays or when I'm in trouble with my mother. I'm physician and pathology trained with a specialty in haematology. Just a little history. I was born in Sydney, but we moved to Melbourne when I was a teenager, and so I'm a Monash graduate. Interestingly, I came back to Sydney in my intern year and completed my internship at Royal Prince Alfred. Stayed on for a few years. Some of you may know that back in those days, the College of Physicians had only just transitioned from a members to a fellowship, and the entry exam into the College of Physicians program was the first part of the fellowship exam, which was modelled on the master on the members exam, which of course was supposed to be done at the end of your training. So it was a tough exam. I went from there into haematology advanced, haematology subspecialty training, along the way picking up, joining the College of Pathologists training program. At the end of 2 years of that in Australia, there weren't really any more challenging places than Prince Alfred to go, so I was fortunate enough to get an appointment overseas. There were a few options, but we wanted to go to America because that's where all the money was for research and all the action was. Chose the one with the better climate, University of California, Los Angeles. 2 years there. Returning to Australia with probably the most formal training in bone marrow transplantation that anybody had to date in Australia. Trouble is, one, the Minister for Health at the time in New South Wales had decided that the reason he couldn't meet his budgets was those expensive specialists he wasn't going to have anymore. So there was a 2-year moratorium on employing new specialists in the public hospital system. That meant that all those very well-trained people just coming out of the system were locked out of the public system, and the private system was the beneficiary. I was running a private practice in haematology as a clinical haematologist half the time, and half the time as the founding haematologist at Douglas Laboratories, and subsequently head of the haematology department. My career in pathology went from there to managing pathologist at one of the other big laboratories. Ultimately, when I made the decision to go rural, there wasn't room for pathology practice in the little hospital I was at, but the coroner found out about me, so I was doing some forensic pathology work for many years, doing most of the forensic autopsies, most of the coroner's autopsies out in Broken Hill. I was then recruited. I was then tapped on the shoulder to become the first chairman of the board of New South Wales Health Pathology, when all of the public pathology providers were merged into one entity. So my career in pathology ended when I stepped down from there after 3 years, moving to Queensland. Haematology, on the other hand, has remained, clinical haematology, on the other hand, has remained the mainstay of my interest. And it is amazing how much it informs general medicine. General medicine was fairly easy to slip back to when I went rural in 1999, because first of all, the very rigorous grounding that the College of Physicians gave you to get the first part exam, and secondly, the fact that haematology infuses almost everything, at least 30, maybe 40% of general medical admissions have a haematology flavour of some sort. You know, whether it's anemia, whether it's immunity, whether it's the need for transfusion, and of course there's the ever-present threat of thrombosis in patients throughout the hospital. It's meant that, you know, being away from the big hospitals where acute leukemia were managed, I was able to look at some of the more interesting and neglected areas of haematology, at least at the time. Things like iron deficiency, things like patient blood management, which is the proper way of looking at transfusion. Transfusion, we're not there just to pour in this fluid. Transfusion is a living cell transplant, and with that comes all sorts of hazards that we need to recognise. And because of my experience with iron deficiency, I was able to help a lot in the whole business of minimising needleless blood transfusion. And it's now, after about a 13-year struggle, I think we've now got to the point where most people think twice before they transfuse and try to find other alternatives. And fortunately, there's a very nice intravenous iron infusion available that's very convenient and nobody's scared of anymore. So now, how did I get into medico-legal work? That was interesting. First of all, there aren't many haematologists around. Back in those days, there were very few in private practice, and given that people in public employ sort of feel a little bit gagged about criticising their employer, the lawyers sort me out a lot of the time. I was also chairman of New South Wales AMA and the whip of the New South Wales delegation at one of the national conferences where Ian Flecknoe, who was at that time a QC, I gather he's now a judge, came in and gave us a real blast about how medico-legal reports are so often biased in favour of the person who commissions the report. And it was there that the expert witness code of conduct was started, and I can say I understand why, and it's really appreciated by particularly the barristers when they know that you're going to give them an objective, evidence-based report that you can back up as far as necessary, rather than one that's obviously tilted in favour of the person paying the bill. There are still a lot of my colleagues around, unfortunately, who tend to behave like those hired guns that Ian Flecknoe was so critical of. But the code of conduct should be a guide for everybody who's writing expert reports. If you can't say something, back it up with evidence, and if you don't really believe it with conviction, don't write it. I think that's all I've got for you, Michelle. I hope that's been stimulating.
I have a question for you, please. It's from somebody who was unable to attend, and they wanted to know an example of a time when you were asked to provide an assessment and where your findings were sort of a surprise or an unusual thing that actually was really good for the person, the injured person.
I'm thinking of one where, there've been a few where I've discovered material that wasn't picked up in the summaries and wasn't part of the argument. I'm just trying to think back to the most recent one, which turned out to show evidence of a thrombotic process much earlier than was suspected. There've been a few like that where close examination of the records has yielded something that changes not just the tone of the approach, but it's very much in this case it was very much in favour of the claim. And it hadn't been picked up anywhere before in any of the other expert reports that had been issued. Of course, it can go the other way as well. And if you find something that is going to contradict what the lawyer has asked you to address, it's obviously very valuable to let them know straight away so that they can reduce the risk of embarrassment at the very least, but certainly reduce the risk of reduce the fee to their client. That's very important.
So what kinds of matters come to you for assessment?
At the moment, the most important source of referrals is this venous thrombosis or pulmonary embolism.
Yep.
And it's interesting because there's not much physical examination needed there. You can see very obviously if a person's developed post-thrombotic venous insufficiency in the lower limbs. You just need to turn so I can do that by video conference. You just ask them to turn the camera down, and there's this purple ankle and purple and swollen calf, and you know, in the case of pulmonary embolism, it's all in the imaging anyway. So by far and away, the most frequent referrals are for that. The presumptive legislation, the presumptive liability legislation for firefighters, is another important part of the referral work, because for those who don't know, initially a few states in the US, one state in Australia, and now all states in Australia, as well as most states in the US, have accepted that there is a link between occupation as a firefighter and certain malignancies. Bladder is obvious because products of combustion get into the system and get concentrated in the urine. But certainly almost all lymphohematopoietic cancers, that's the term used in the Monash firefighters health study. So that includes myeloma and hairy cell leukemia and rare ones like that, but most importantly non-Hodgkin's lymphoma. There's a steady stream of those, and it's very important that those firefighters get a proper assessment, one that is not going to be tossed back and forth, and so that they get what they're entitled to under presumptive legislation.
Okay, well, I was going to ask about firefighters, but you put that in yourself. Does anyone have a question that they would like to ask? If you unmute yourself, you should be able to do that.
I thought I saw Donald. No, you muted. You muted, Donald.
Scroll down to the bottom of your screen, and a menu bar should pop up, and there'll be a thing that looks like an old-fashioned microphone.
Can you hear me now?
Haven't got it yet.
Now?
No, we've still got no sound. You are unmuted, but we've got no sound, sir.
Put your cursor across the bottom part of the window that's open there, and there you'll see it. Far left.
Yes, I've got rid of the mute.
That's it.
Got you.
We got you.
Okay. In your career and now, does immunological problems come within your purview? Well,
yes, I trained before immunology became a subspecialty in its own right, and anyway, lymphoma is all about the immune system and and you've got to, if you're gonna understand lymphoma properly, you've certainly got to have a very good grasp of how the immune system works. Look, rheumatologists tend to handle most of the autoimmune disorders. As you know, as you may know, that vaccine-induced thrombosis with thrombocytopenia was not a thrombotic disorder. It was an immune disorder due to the formation of an antibody against part of the vaccine and part of the platelet. So yes, you've got to be across your immunology to do this work.
Wow. Anyone else have a question? No? Thank you so much all for attending this. This recording will come out to you within a day or so, and it will also be saved to our YouTube channel so you can watch it again if you choose to do so. Thank you so much, Steve. It was really interesting to hear from you. And I understand you're doing an assessment for us soon. And I know that your work is pretty excellent, so I look forward to having a read of that. Thank you, everybody, and have a great rest of the day.
And Ludwig says goodbye too.
Oh, I was going to ask about Ludwig. Do you play?
No, I don't.
Neither do I.